A very good evening to everyone. Thank you so much for joining in for our 17th POWWOW. This month's topic of focus is cornea. I would now like to invite Dr. Srivalli ma'am to take over as the moderator of today's discussion. Over to you, ma'am.
Good evening, everyone. Welcome once again to this 17th POWWOW. Thanks to Dr. Shikha and Dr. Sugneshwari, the program directors, who asked me to put together the cornea cases for this month. So this month's presenter is Dr. Prabhat. We all know him, and I'm sure he has a lot of interesting cases with him. Thank you, Dr. PP ma'am, for agreeing to be the presiding chair for this session. And we will have two cases. The first case will be the expert panel is Dr. RR ma'am. And for the second case, we were supposed to have Dr. Shweta, but unfortunately, as she cannot join, Dr. Mukundan will be the expert panelist for the same. The concluding remarks will be given for each case after the case is over by Dr. NR ma'am. And thanks once again to Dr. NR ma'am also for just agreeing to do the concluding remarks at a last minute notice. I welcome all the people who have joined, and sorry for this delay, but without any further delay, we'll start off with the first case presentation. Over to you, Prabha.
Thank you, ma'am. And of course, I'd like to thank the cornea department and the POWWOW team at SN Chennai, which is my alma mater and my most favorite place in the world, for this wonderful opportunity. So that's because I would like to take the discussion in those directions. So so I start with my case. So the first case is a 66-year-old male who was complaining of diminution of vision in his left eye 2 months prior to presentation. He was unable to move around independently and confidently, and that is because he was one-eyed. So he had a history of left eye cataract surgery 10 years prior. There was no history of trauma to the left eye, chemical injury, no history of recurrent redness or long-term use of topical medication. And as I mentioned, he was one-eyed. That was his only eye. The right eye had undergone enucleation 3 years ago post-trauma. So just a slit lamp drawing showing a shell in situ in the right eye and a near total thinning in the inferior paracentral cornea in the left eye with good pseudophakia. Best corrected vision was 660 and 36 in the left eye. So we have a diffuse illumination slit lamp photograph, and you can see the inferior paracentral thinning. In fact, it's almost, there are some features similar to ectasia in the sense you get a Fleischer's ring here too. You have pigment deposition, and if you look closely, there is a fish mouthing of the stroma, and that is because the stroma has given way in that central area, paracentral area. So that is also seen very well on the slit image. So these are the ASOCT line scan, horizontal and vertical. So I'd like to divert the attention of the residents and fellows to the vertical line scan that is passing through the apex of the cone. So this is not actually an ectasia, but there are some very interesting features here. When you look at the central area, you will see the epithelium is very, very thin at the apex of the that central thin area, and beyond that the epithelium has thickened. So I'm just going to take a short detour from the management of this case and talk about epithelial thickness in an ectatic cornea. What happens in keratoconus is also happening here, where remember that the cornea and the epithelium has a tendency to maintain the topography. So at the apex of the cone, where it's steepening more than it should, the epithelium will thin out. At the base of the cone, where it's flatter, the epithelium will thicken. That is all to maintain the topography. This is what is known as compensatory epithelial hyperplasia. Now we go back to the OCT and we see clearly the compensatory epithelial hyperplasia striving hard to maintain the topography in homeostasis. So coming back to the management of this case, proper centration. I always put a Flaringa ring for a DALK just to be safe. Partial thickness trephination, initial layer of dissection. To use these blunt scissors in DALK, again just to be safe. So inferiorly it gets trickier because we're very close to the Descemet's membrane at that paracentral area. And you can see the exposed Descemet's membrane right there. So we leave that area, we continue in a second plane and continue the dissection in a similar manner, spiraling deeper as we go. So there wasn't enough space to pass the crescent at this layer, so I tried to do it with a spatula, but I couldn't maintain the plane at this point. So we just peeled whatever layers were available, cut off the protruding stromal fibers and sutured the graft. So this is a photo from post-op day 1 and 2, and we can clearly see the significant disparity in the thickness of the residual stromal bed, because while I could complete about 3 layers on one side of the central paracentral thinning, I could not complete 3-layer dissection on the other side. So this is an image from 1 month post-op. The BCVA was stable, and it continued to stabilize and improved a little bit at about 10 weeks, when it improved to 636 with a significant residual cylinder. This is from 4 months post-op with a cylinder of about 9 diopters and vision stable at 636. And we see a huge difference in the residual stromal bed. On one side, it is about 43 micron, and the other side, it is about 200 microns. So that is, like I mentioned, because we couldn't go deeper with the dissection, but it continued to compact, and fortunately, there was not a lot of residual haze because of the residual stroma. So further follow-up, 1 month post-DALC, we've removed a few sutures in a topography-guided manner. The K values have come to near normal range of 46 and 44, and the BCV has improved to 618 with a -3 diopter sphere. So again, just for the residents, that as we know, the stroma cornea contains 6 layers: epithelium, Bowman's membrane, stroma, the pre-decimetic layer known as the Dua's layer, which is a condensation of the posterior stroma, and the Descemet's membrane. So the gold standard for DALC at this point in time is the big bubble, wherein you inject air into the deeper stromal layers and try and separate the stroma from the pre-decimetic layer, which is known as a type 1 bubble. If you end up injecting the air in between the pre-decimetic layer and the Descemet's membrane, it's known as the type 2 bubble. We try to aim for a type 1 big bubble because it is safer to have residual stroma left behind rather than bearing the Descemet's membrane completely. In this case, however, I did not feel that it was a great idea, because that paracentral thinning I felt would not provide enough stroma to be able to bear the pressure that's created within the cornea at the time of a big bubble, and therefore I thought that doing a manual dissection would be a better and safer idea, particularly in a one-eyed patient where risking a large perforation meant converting to PK, which did not seem like a wise idea at that point in time. So DALC, of course, allows us to preserve the host DM, thereby significantly reducing the chances of rejection. In addition, the residual host tissue layers provide tectonic support, and in the event of a severe blunt trauma, the possibility of a full thickness defect, that is a globe rupture at the graft pore junction, is reduced quite a bit. So as I mentioned, big bubble involves air injection into the deepest layers of the stroma. In the absence of adequate stromal tissue in the thinnest area, it was felt that the bubble might rupture the DM. Therefore, a manual DALC was chosen, and what I was actually trying to do was to dissect layer by layer, eventually end up at the pre-decimetic layer, and then finally use a groove and peel. So I'll just mention what groove and peel is. I don't have a video, but of course, as we all know, we'd like to give a shout out to Dr. Rishi Swarup sir for this wonderful technique. I've put 2 arrows. The longer arrow shows the first layer of stromal dissection, and the shorter arrow shows the second layer of stromal dissection. So you continue dissecting like I was doing, and at one point you give counter traction in the area that I have marked out, and then with another forceps you hold the stromal layers and just peel it across from one side to the other, thereby bearing the pre-decimetic layer. So it's a very good alternative for those who do not want to do the big bubble, but at the same time want to achieve a near decimetic or pre-decimetic dissection. So I wanted to ask the panel and the respected chair, what are the other management options available? We did discuss scleral lenses, but is there anything else? Does the one-eyed status make us more or less likely to intervene, given that he wasn't able to do his day-to-day work, and he was really struggling with his quality of life? So how would the surgical approach differ to ensure deeper near decimetic dissection all around? And do we expect the lack of deeper dissection on one side affect the long-term visual acuity? And what could be the possible etiology? Thank you.
Yeah, thank you, Prabhat. That was a real heroic, adventurous surgery, I should say, and congratulations on doing it well and getting a good outcome. What was the preoperative vision you had mentioned?
660 and 36.
Okay, so more or less he did have an improvement, and hopefully that would be with a more stable cornea. I would like to invite Dr. Rama Rajgopal ma'am for her expert comments.
That was a very nice surgery. Can we go back to your first OCT image, please?
Yes, ma'am. Yes, ma'am.
You had one AS OCT also. Epithelial thickness, how much was the thickness there, you said?
I don't have access to the epithelial mapping.
Okay, fine.
But it's quite evident that there was thinning at the apex, for want of a better word, the apex of that area, and thickening all around.
So can you go back to the earlier image, Prabhat? The one that you put up before this or after?
Is this it?
No, there was one more OCT, right, where we could see the thinning in the periphery. Do you have one more image of the OCT?
No, ma'am.
Yes, Prabhat, the horizontal and the vertical. This one.
This one.
No, this is from an article, ma'am.
No, not this. The previous, just the previous one.
Okay, let me know if I'm on the right slide.
No, I was thinking the other one that you showed, is it from your patient or from the article?
This one. This one.
This is mine.
This is the patient, yes.
This is the patient.
Yeah.
So, couple of things, Prabhat. I understand that there's a limited access to Pentacam. Do you have a keratometric value or something like that for this patient?
From this visit, I don't have it, ma'am. Only after the surgery I have.
So, I also would like to ask you, this patient had poor vision from childhood, isn't it?
No, ma'am. No. He was only giving a history of about 2 to 3 months. No history of trauma.
Is this a pseudophakic eye?
It's a pseudophakic eye. Yes, ma'am.
So the cataract, when was the cataract done?
10 years. 10 years back.
So is there any posterior capsular opacification in that case? Because he's an elderly patient,
yes,
you have a problem in the cornea, which is, I feel, must have been stabilized by the time he's 50. And then he's had a cataract long ago, but he's having a decrease in vision. There is no other comorbidity in the eye. So is there any other reason why he could be having this recent decrease in vision? Everything else in the eye is fine?
So he has a small epiretinal membrane that was deemed to be non-contributory to his diminution of vision by the retina surgeon.
And do you, sorry to ask you, do you have a histopathology of this specimen that you took out from the eye?
No, ma'am, because you get layer dissection, so we normally don't send talc for histopathology, only PK.
Okay. So I obviously, I think I've not seen the patient, but the one question I'm having, I would like to ask Dr. PP ma'am also. So if in these kind of situations, is posterior keratoconus a possibility at all is one thing that I'm looking at from the history, from the fact that, that he's been having it probably for a long time. It's probably been stable for a long time. I can just about see a little bit of deficiency in the posterior layers. There's a little bowing that you expect in these eyes. PP ma'am?
Yeah, Prabhat, I too was curious. First, I was curious to know whether this is a progressive condition or whether it is a static condition. And two, what was the indication for enucleation in the fellow eye?
Ma'am, so this was his first visit with us. So he just gave a history of trauma to the right eye that led to enucleation. Whether, I don't know whether that had a similar condition which therefore would have made it more susceptible to, traumatic complications. That I'm not quite sure. But that's the only history we had because the enucleation was not done at our hospital. It was done elsewhere 3 years prior to presentation. So we really don't know much about it. And his history was very vague beyond that point. He was unable to tell us in greater detail.
And the thickness in the rest of the cornea was normal?
Yes, ma'am. With the exception of this inferior paracentral area, the thickness in the rest of the cornea was normal at presentation.
And the Descemet's membrane was intact?
Yes, madam.
Okay. The possibility of a posterior keratoconus, I would keep in mind.
Yes, ma'am. Yes, I didn't think of it at the time. But
so, ma'am, so I think, Prabhat, if it was posterior keratoconus, I think quite often we all know that at this age it's not possibly doesn't progress. So if we had the access to the pentacam, we will be able to understand, because the keratometry is not going to be very steep as much as possibly you will see it in an anterior keratoconus one. And then although there can be a little bit steepening because of the posterior pushing from the keratoconus, from the deficient Bowman's and the desmus membrane. And the other thing, a specular also would have helped. But clinically, I think it looks like the cornea otherwise is reasonably compact.
Yes,
as far as the, so I think based on the indication, we possibly have to, and the single-eyed status, we probably have to decide whether we need to just do the, look for other comorbidities. Are we just going to just decide on just doing the transplant in this situation? Because I'm not able to understand what is something new that has developed that led to the problem in the progressive condition in the cornea, because of which he required surgery, number one. The second point is, suppose we assume that it is a keratoconus, there is a definite indication for surgery, because obviously you are the best person to judge, because we have not seen the patient or we don't know the limitation in terms of vision and all the patient is going through. And you said clearly he is not keen on contact lenses. I think as far as surgery goes, in my mind, I think the manual dissection, the indication is only manual dissection in this case. There are no two ways about it. When you have progressive thinning with ectasia, be it trauma, be it keratoconus, be it, of course, keratoconus with very thin cornea, or be it high drops with a scar, or be it a patient with PMD, inferior PMD, or be it a patient with a macular dystrophy where the endothelium is bad and you have a very thin pre-desmet membrane involvement. In all these cases, but if there's a thinning in the macular dystrophy, I definitely prefer the manual dissection. I think the technique is very individual, because when there is a thinning, based on the, if we have access to the overall thickness of the cornea, we can decide like what is classically described in the periphery. You go about 80% or 2/3 thickness and take that part away. But if you're actually looking at a cornea like this, which is very thin in the center, I think what you did is perfectly all right. Based on the OCT thickness, you can decide what is going to be the initial extent of depth that you're going to go through, based on how thin that projection, the area of the cone or whatever you want to call it is. From the periphery, as you access, I don't think glue and peel can work much in these eyes, because unless you're going really deep, you won't be able to peel the layer. Unless you are in the Duas layer, you can't really do the glue and peel very effectively. Maybe in the periphery you can, but once you access the center, it's going to be very, very difficult. So what I would suggest is only two things. One is, of course, the role of paracentesis once you get closer to these, to the area of the involvement. And the second thing is, I think keep your, do not do anything that will tent this area even further or make it more taut, because once you reflect and you keep your left, whichever hand you're using, if you lift it up and not stay parallel to the surface, then there's every possibility that there's a, wherever there is a scar, sometimes there's a peripheral thinning around the area of the scar, and that area can actually give way. So all your movements should be as horizontal as is possible. And of course, you want to use a blunt instrument when you go closer. Like you rightly said, you do the periphery first and then you come to the center, so that you have finished everything, and see with the blunt instrument how much you're able to separate the layer. Of course, the role of paracentesis we have already highlighted. I don't think there's anything else that we could have done to make the surgical technique any better. The only thing is, this opacity, fortunately for you, is a little paracentral, right? So because it is paracentral, I think you can get away with even a little bit of scarring in the interface, because it's possibly not going to interfere with the vision as much as somebody will probably have it in the visual axis.
Yeah, thank you, ma'am, for those pearls, and thank you, PP ma'am, also for your input. And I think, ma'am, Radhika ma'am, you will be you wanted to give your inputs as well.
Yeah, hi Prabhat. That was a very nice case with a very happy ending. So to quickly summarize all the points that were said, that was the task that was given to me at the starting of this meeting. So first to be considered is the fact that the patient is single-eyed before we get more involved in the surgical details, which means our caution has to be double. And according to the patient, it was a history of 3 or 4 months of reduction in the vision. So if I were you with somebody with a 660 vision, I would wait for a little longer, because we really don't know what that posterior bowing is because of. Posterior keratoconus was discussed. It may or may not be that. sometimes shows distinct changes in the decimates in that area, if it is posterior keratoconus. One other entity that can closely mimic posterior keratoconus is healed disciform keratitis. It's an archaic term, but I prefer to use it because it brings clearly to mind that there is a localized disc of pathology in the posterior stroma and endothelium caused by viral entity or other entities. And when it heals, it produces an exact similar picture like posterior keratoconus, with that bowing, with that thinning, with that mild protrusion, little bit of pigment on the posterior surface. If it is indeed that, then I would like to see whether it is progressing or recurring, before touching the eye for surgery. And this patient couldn't afford POWWOW contact lens, but like you rightly said, it may have been the first option. Even if he couldn't afford, I would have prognosticated the vision with a POWWOW contact lens before doing surgery, so that we know how much the cornea contributes to the loss of vision, or the curvature, how much it contributed to the loss of vision. When you do use a Fleringa in these cases, the pathology is peripheral, so it's better to use a big ring or better to decenter the Fleringa ring when you're using it in this case. And knowing the cause or waiting it out is of paramount importance, because difficult as the surgery was, you pulled it off marvelously. But more important is to retain the graft. We should not lose the graft to the same original pathology. So things like, looking at the button, waiting it out to look for recurrences, are important to keep the graft intact after the surgery. So caution with a single-eyed patient, prognostication with POWWOW contact lens, keeping posterior keratoconus and disciform keratitis as a differential diagnosis, and giving a little waiting period to know that the disease is actually quiet before doing the surgery, and well thought out suture removal for quicker visual rehabilitation in a single-eyed patient. These would be my pearls from this case.
Thank you, ma'am. Thank you.
Thank you, ma'am, for summarizing it so well. Dr. Mukundan, you also wanted to add a few points?
At the outset, Dr. Prabhat very nicely managed this patient. My one doubt was, sorry, might be the video was in between stuck. I was not seeing properly. How did you remove over the thinned out area, the epithelium, by manual dissection only?
No, so, I was just dissecting all around, and then I lost the plane after maybe 2.5 circles or something. So whatever I had, I just pulled it across, so it came. I was fortunate. And in terms of the area of maximum thinning, underneath the first layer, it was just the desmas. So it came off on its own. You can.
That's what might be. I was also thinking, might be, can we use just alcohol and then remove epithelium over that area rather than peeling? Might be. I was like other option I was thinking, because seeing the asocity, that area is very thinned out, and like the rest of the dissection over around, and in the thinned out area, can we just keep an alcohol and just remove the epithelium? That was the different thing which I would have done. Might be that's. And as Enna ma'am told, I would have thought HSV necrotizing, post HSV keratitis as one of this thing, and as RR ma'am told, might be posterior keratoconus, which actually I didn't think about. Maybe I should consider that. Okay, otherwise very nicely managed.
Thanks.
Thank you all for those inputs. Was there vascularization around that area?
I saw him twice. At the first visit, there was no vascularization. And just before the surgery, inferiorly, there were a few vessels, closer to the limbus. But none of it was reaching the area of maximum thinning. And it was superficial, not deep.
Okay, thank you. So there's just to consider all the differential diagnosis.
Yes, ma'am. I understand.
As everybody has said, it's good. You were adventurous enough to go and operate on a one-eye in this situation, and it turned out well for you. But as everybody has pointed out, maybe the pentacam to begin with, and the idea of doing the lens, and first of all, a scleral contact lens, and to see whether the vision improvement was happening before we subject to surgery would also be a good thing going forward. In such cases, I think just knowing that the patient would do well.
Yes, ma'am.
PP ma'am, would you want to add something before we move to the next case?
No, I think you all summed it up very well. Let's move on.
Okay, ma'am. Thank you. So, Prabhat, can we have your second case?
Yes, ma'am. Just moving across through the slides. So thank you everyone for the wonderful inputs. I always learn a lot when I discuss with my mentors at Shankar Netralaya. And coming to the second case, this was a 21-year-old male with a history of desquamative.
Prabhat, we are not still seeing your discussion slide from the. Yeah, now it's correct. Yeah.
Wonderful. So I'll restart then. Okay. So my second case is a 21-year-old male with a history of desquamative lesions with oral ulcers 2 to 3 years back, along with both eyes redness when he was treated for a fever. So he doesn't know which agent was used for treatment of his fever, but everything happened after he was treated with some antibiotic. The best corrected vision at presentation was CF 1 meter in the right eye and CF 2 meters in the left eye. So this is an image of the right eye showing corneal haze with a disrupted light reflex and in the right eye, and a near total cataract with vascularization and congestion. And the left eye also, there was vascularization, immature cataract, and a disrupted light reflex with discharge. So there was no lid margin keratinization. Right eye was showing a disrupted light reflex, corneal haze, vascularization, and near total cataract with conjunctival congestion. Similar findings were noted in the left eye with an immature cataract and discharge. Based on there was no lid margin keratinization. This is the image with fluorescein staining using cobalt blue filter for illumination and Ratten number 12 for viewing, showing 333 punctate epithelial erosions in both eyes and a severe dry eye. The Shermer's test was 0 in both eyes. Syringing of the lower puncta was patent. The upper puncta was seen, but syringing could not be done because they were just too small. And the fluorescein clearance test showed 1 mm at 10 minutes, 0 mm at 20 minutes, and even after nasal stimulation, that is the reflex tearing was completely absent, so it was 0 at 30 minutes as well. So based on the clinical examination, the history and the investigations, a diagnosis of Stevens-Johnson syndrome was made. We advised a thermal cautery of both eyes, all 4 puncta. The right eye, both puncta were successfully cauterized. The left eye lower punctum was cauterized, but during the procedure, I could not identify the upper punctum due to its extremely small size. So these are images from 1 week after the punctal cautery, showing scarred upper and lower puncta of the right eye and scarred lower punctum of the left eye. Now, this is 1 week post punctal cautery in the right eye, and you can clearly see that the fluorescein staining has reduced from 333 to 1, 0, and 1. And while the lower TM meniscus is not visible, post-operatively the upper TM meniscus is clearly visible in the left eye, and there is the eye is much more moist than what it was prior to cautery. This is the left eye before and after punctal cautery, and there was a little bit of improvement, but there was still a lot of fluorescein staining. There was still a lot of punctate erosions. The eye was still very, very dry. The surface was still vascularized. There was still congestion, and most importantly, the patient was still extremely symptomatic in the left eye as compared to the right eye. Now, when we look at the asymmetric response in both eyes, I felt that there was a possibility that although I could not see the punctum during the procedure, the upper punctum of the left eye, there was a very real possibility that it was patent and it had taken over the drainage from the cauterized lower punctum. So I repeated the syringing under slit lamp illumination this time, and I was able to locate the punctum, and therefore I advised recautery. Now, what I did on the day of the second punctal cautery, that is, this time we're only going to cauterize the upper punctum of the left eye, was that I used the Bowman's lacrimal probe and colored it with gentian violet and used it to dilate the punctum. But because I colored it with gentian violet, the punctum got marked out, as you can clearly see here. This was to avoid missing out the punctum on table again, because often what happens in Stevens-Johnson syndrome is that the tissue around the punctum tends to contract, so it hides the punctum because of the discharge and because of the fibrosis. So we couldn't risk that happening again, so it was important that we identify the punctum prior to the procedure and therefore not miss it during the procedure. And so I was able to successfully cauterize the punctum in the second attempt. So this is from 1 week after the second punctal cautery, and while the congestion has reduced a little bit, the vessel caliber of the supero-nasal vessel has also reduced, and the eye was extremely moist at 1 week. This is a 2 months follow-up of the right and left eye, and the most striking thing I think about this image is, well, of course, both eyes look much more moist than what they were before, but it's the compaction of the light reflex. The light reflex is extremely distorted in the right and left eye prior to cautery, and it's fairly regular in both eyes 2 months after cautery. So again, a drastic change in the fluorescein staining. It has reduced from 333 in the right eye to almost no staining 2 months post cautery, and in the left eye from 333 to about 100. So, and the patient, of course, was completely asymptomatic. In fact, I saw him just 3 days prior to this presentation. And also, we can clearly make out the upper tear meniscus in the right eye and the upper and lower tear meniscus in the left eye, and we can see that they're adequate. So this is his topography just 3 days prior, and it has regularized a fair bit in the right eye, but in the left eye, in addition to some amount of persistent dry eye, there's also a lot of corneal scarring, which may lead to the irregular astigmatism. So punctal occlusion is a relatively simple procedure for severe dry eye. Punctal plugs or thermal cautery can be done. I'm on the discussion slide now. So as I was saying, punctal occlusion is a relatively simple procedure for severe dry eye. Punctal plugs or thermal cautery can be done, but thermal cautery it's inexpensive, it's less technically difficult, and it does not have the risk of plug extrusion and other such complications. So in SJS related dry eye, I found that thermal cautery has been very sparsely described in literature. In fact, I couldn't find anything. Other options for SJS related dry eye include scleral contact lenses and also minor salivary gland transplant. But you know, with scleral contact lenses, when they're not wearing the lenses, they will continue to remain symptomatic, which is a significant part of the day. In fact, it's 16 out of 24 hours. And MSGT is a highly technical procedure, and you will end up causing a little bit of fibrosis, you know, in the mouth as well. And it may or may not last for a very long time. So and this is what I learned from the ocular surface department at SN. But so all of us who have been trained at Shankar Netralaya, we all prefer the thermal punctal cautery because of the ease of the procedure and the wonderful results that it offers. But for reasons that I do not fully understand, when you discuss this with those who have trained elsewhere or those who are working elsewhere, they tend to disagree with the plan of management. So I just had a few questions for the panel. Where do we decide to try scleral contact lenses or salivary gland transplantation? It is quite evident in this particular case that single punctal cautery, that is lower punctal cautery alone, was inadequate in the left eye. But is there a situation where lower punctal cautery alone would be considered? And the patient has now been advised cataract surgery for the right eye, which has a near total cataract. And later we will also do a cataract surgery for the left eye, which has an immature cataract. So is there any role for toric IOL in a condition like this, assuming that it has stabilized? No, we have advised a monofocal IOL, but I just wanted to know what the panel thought. Thank you.
Thanks, Prabhat, for bringing out this very important aspect. And as you mentioned, it's a very inexpensive mode of treatment and should be done much more, can be done with everybody. That's, I think, the main advantage. But rather than taking these questions, I will let each of the panel members to answer these. So can you please begin the discussion, Dr. Mukundan?
Yes, ma'am. Nicely managed case, Dr. Prabhat. Then, as you mentioned, like I was also trained from the other institute and then only joined SN. So, punctal cautery is, no, it's like correct only. Punctal cautery is not commonly performed in other places, but it's a very simple magical procedure, which I also saw the magic after joining the SN. It's a very simple magical procedure that brings back the moisture to the eye. and reduces the further corneal damage. I completely agree. Like punctal cautery is not, it's done, but not as done as in SN. So it's a very, like as you told, it's a magical procedure, and we can start seeing the result in 2 weeks. It might be in day 2 or day 3 only. Sometimes there'll be more reflex tearing, and patients will be very happy with the punctal cautery. And the other thing might be with the fluorescent stain. Sometimes when we see the patients for follow-up on slit lamp examination, sometimes we'll feel it's tenosed only. But with the help of stain, we can be able to, this fluorescent stain with the green filter will also help us to identify and detect this puncta, if it's partially stenosed or not. And might be the message to fellows is you have beautifully shown the pictures, like the punctal cautery pictures. Like it should be that eschar formation should be there. You have well cauterized, like that eschar formation is completely necessary to to have a very good punctal cautery. Otherwise, a partial burn and all, it will recanalize faster. Then there is no use in doing a punctal cautery. And as everyone knows, we should avoid always topical steroids. Sometimes patient will be some patients for the inflammatory condition SJs, they'll be using on topical steroids. Then post punctal cautery, we should always avoid topical steroids. Even if the patient is using, we have to stop. Otherwise, there is a high chance of recanalization. And rest all points have well covered. Then regarding lower punctal cautery alone, if there is not much fluorescent staining, might be like if you feel Shermer's is low or borderline like 5 or 6, and when the fluorescent stain is like not like as in this case 333, might be like 1, 2, or like there's partial fluorescent staining, we can consider a lower initially to see. And patient has good emotional tearing, maybe we can try only lower punctal cautery and see the response, and based on it might be later we can decide on upper punctal cautery.
So Dr. Mugundan, are we doing single punctal cautery at SN currently? Because
yes, like some cases, I'm not sure about only lower punctal cautery. I was always like, I've discussed with Dr. Shweta also. She, Dr. SL ma'am will always suggest upper punctal cautery, mainly for SLKC, where there is more superior conjunctival staining and UTC inflammation. Like we have done upper punctal cautery alone, but not sure of lower punctal cautery alone. Most of the time it was upper punctal cautery alone. Mainly in SLKC cases, like I've done a patient who was symptomatic with superior cornea and conjunctival staining, upper punctal cautery alone was done.
So it tends to kind of retain the moisture in that area.
Yeah, and the patient gets better, definitely.
I think that's a great new point that you have shared.
And then other thing might be, before, if you want to know whether it's working or not, we can try a temporary punctal plug also.
Right.
And then, or a catgut suture, something to block initially and see the response. And if you're seeing a response, you can go ahead and do the single punctal cautery.
Yeah, thanks.
Then, otherwise, like BOSP lens is very commonly given for outside SJ, for this SJS patient. Another thing that can cause the redness and this thing can be, there can be recurrent inflammation, but most of the time after treating the dryness, the inflammation also comes down.
Subsides. You know, as I mentioned, while scleral lens I think is a wonderful option for these patients, my only concern is two concerns actually I have. One is that when patients with ocular surface disease use scleral lenses, they develop a lot of
debris
underneath the lens.
Interface.
So that actually reduces the wearing time. So for instance, for a keratoconus patient, you would give 4 hours, 1 hour of break, and then another 4 hours. So here it would probably end up reducing to 3 or 3.5 hours, then an hour of break, and then 3.5 hours.
Correct.
Which means that you in a day of 24 hours, okay, fine, in a day of 17 hours where the patient is awake, you are only able to give the lens for 7 hours. So for the remaining 10 hours, the patient is still very, very symptomatic. So that is one. I agree that, we've also talked about and seen images where the vascularization and everything comes down with the scleral lenses. But my only concern is the intervening period when they're not using the lenses. I feel we need to do something about that also.
Yeah, exactly. Correct. But I completely agree. Punctal cautery is a very good procedure for any severe dry eye patients. First we do punctal cautery, then reduce the dryness, and then see we can treat the cause. It can be SJS or OCP also, any condition of severe dry eye or post-adenoviral conjunctivitis.
Right.
Yeah, thanks, Dr. Mukundan. And Prabhat, as he was mentioning it, I don't think you're talking about punctal cautery versus scleral contact lens. The idea is that these are all adjuncts.
Adjuncts, yes, ma'am.
You actually punctal cautery improve it, but still the irregularity would go only if you give a scleral lens on top of that.
Yes,
so
ma'am.
I think it's not just this or that, and depending on the case, you would be choosing one or two or three of these things which you would be doing on a case-to-case basis.
So, can I ask another question?
Yeah, please.
I mean, a lot of people, I think in Brazil in particular, they practice a lot of minor salivary gland transplantation. So I just wanted to know Dr. Mukundan's opinion on MSGT and the role in SJS patients.
Actually, regarding, I also seen very few heard about or seen case reports where minor salivary gland transplantations been done, and they also do well. But clinical wise, no, like zero experience.
Okay.
Now, it might be they'll be very good for the patients where lacrimal gland is completely fibrosed. Where there's even the accessory, the other accessory lacrimal gland also have less tear production. Right. So even the punctal cautery doesn't help. Might be those cases it will be a good option.
So probably recalcitrant cases where like you mentioned, punctal cautery has not worked, and then you need to do something else. So either you choose scleral lenses and or you do a MSGT.
Okay.
Okay.
Yeah, thank you, Dr. Mukundan. Regarding the choice of the lens, maybe I would like to ask PP ma'am, would you like to give your expert comments? And in such situations, if things are improved, would you actually consider toric IOL is what Prabhat's question is?
Yeah, before I answer that, I have one comment and two questions. The comment, of course, is that Prabhat, it's always a pleasure listening to your
thank you.
I like the way you document things, and I like the rigor with which you approach your management.
Thank you, ma'am.
The question I had was, you mentioned that there were, other than SN, everyone else frowns upon punctal cautery.
Yes, to put it mildly.
Yeah, what the reservation was, and what is the reason for their reluctance to do punctal cautery?
All right. So, thank you, ma'am, for that question. So I have spoken to people from AIMS and LV Prasad also, and other places also. So the overall concept is that they feel that doing a punctal cautery would lead to epiphora. And for the most part, they're not completely wrong about that, because yes, I mean, if the Shermers is, say, like Mukundan mentioned, 6 or 7 or something like that, then if you cauterize both puncta in one shot, then you're likely to have a little bit of epiphora, and that's completely understandable. And the other thing is that they fear the irreversibility of the procedure. So, like for example, if you put a plug, you can pull it out at any time. So there's a lot of comfort in that thought, the fact that you have full control over what's going to happen going forward. In that sense, I feel that because we do the fluorescein clearance test and we look at the reflex tearing, we know that no matter what, there is not enough tearing in this eye, and therefore doing a punctal cautery is unlikely to lead to secondary epiphora. Therefore, we are able to go ahead with punctal cautery of both puncta with a fair degree of confidence. So doing the FCT, I think, is what differentiates our thought process from everybody else's when it comes to punctal cautery.
Right. So my second question then, it's actually an extension of this. If you obviously, you're doing the punctal cautery because you want an irreversibility of it.
Yes, ma'am.
You just do a punctal plug or something. And therefore, how important is it to make sure that even the canaliculus is cauterized to reduce the chances of recanalization? And how would you do that, canalicular cauterization to ensure an adhesion?
Okay. So, ma'am, thank you again for that question. When I was a resident AVCD, I used to, and I was posted with Dr. SAL, I used to push the cautery tip into the vertical canaliculus and turn it around, thinking that I will cauterize as much as is possible up till the common canaliculus. But that can't work because beyond a certain length, the tip will not go inside. So you're still very much going to cauterize only the vertical canaliculus. So one time during my fellowship, I saw Dr. GKI do exactly how it's supposed to be done. And Dr. Mukundan, please correct me if I'm wrong, but my understanding is that we only cauterize the vertical canaliculus, and we cauterize it completely. Once we see that SR formation, we come out. At the point where we're coming out, there's a little bit of risk of pulling the SR out completely. So in addition to that, I also just run the cautery tip across the surface of the punctum just as an add-on, but I don't know whether that is being done at SN. We are not able to cauterize the horizontal canaliculus, only the vertical.
Do you want to add in?
Yes, ma'am, might be the tip position is in such a way that I think only vertical canaliculi can be blocked. And
Yes.
as Dr. Prabhat has mentioned, we go inside, first start the cauterize from the canalicular and then come to the puncta, and we see a dark eschar is formed.
Black,
If not,
yeah.
we repeat again.
Coming to the question of toric IOL, I think it would depend on how much of this astigmatism is regular and how much of it is irregular. So, obviously, if if there is a regular astigmatism, the toric IOL is a no-brainer. But if there's going to be an irregular astigmatism, how much you're going to rely on that on those topography maps with such an irregular cornea? The irregular astigmatism is not going to be corrected with toric IOL. So while it's not a contraindication for a toric IOL, you need to know how much of that astigmatism can in fact be addressed by a toric IOL.
Yes, ma'am. Thank you, ma'am. And when we were just talking about the procedure, Prabhat, can you also mention if you have the power settings? So for the benefit of everybody, that any particular...
Ma'am, no power settings. It's a battery cautery. It's the same one that the VR surgeons use for the Yamane SFIOL and the glaucoma surgeons use for doing a GAT and melting the suture. So it's the same one. It's just a battery powered cautery. I think multiple companies are making it now. So no power settings per se.
Yes, ma'am. There is a video uploaded in our Ocular Surface Gurukul on punctal cautery. Our fellow alumni, Dr. Sharath TSK, helped us to make the video on punctal cautery. So might be people over here can watch the video.
Yes, thanks.
It's uploaded in Ocular Surface Google. Might be 2 months ago. I think. It's a video on punctal cautery.
Yeah, actually, and I'll take this opportunity to inform everybody that the Ocular Surface team is doing a very good job of putting out videos every month, which are really explanatory, and they go into the depth and made it simplified for everybody. And this is Ocular Surface Gurukul, which is freely accessible for everybody. Like to ma'am, Dr. RR ma'am, would you want to give any input for this case?
I just have one question for Dr. Prabhat and Mukundan. Prabhat, both cases are very beautifully presented. So sometimes when you have borderline dry eye with Schirmer's and cataract, you may want to combine the two. But if it is a severe dry eyes, then you probably want to do the cautery. Wait for surface stabilization. Is there a minimum? Because quite often you see the improvement in a week or 10 days time. Once the tears film is adequate, then the inflammatory component all comes down. Is there a minimum time that you have to wait before the surgery in these cataract surgery in these eyes?
Ma'am, I feel better to wait for a month or so because let the wound get healed completely. Because post cataract surgery will be giving a topical steroids, which will again interfere with the wound healing and can cause recanalization. I feel at least we have to reassess after 1 month to 6 weeks, then we can plan. Might be only in a case of total intumescent cataract where we feel we cannot give a longer time, might be a shorter duration. Otherwise, we can give 1 month to 6 weeks time.
Yeah, I would also wait for at least a month, ma'am.
Okay, thank you.
I would like to invite Dr. Radhika ma'am for her concluding remarks for this case also.
Yeah, sure, Srivalli. That was a very animated discussion between Prabhat and Mukundan. I really enjoyed it. I should say, though I don't treat ocular surface cases, I see a lot of them which I start the primary treatment and refer them to the ocular surface clinic And knowingly or unknowingly, this case of Prabhat and his presentation were studded with pearls. The first of them being the surface staining that he showed, where he had used the yellow filter. The Ratten 12 filter, which is available on modern slit lamps or any other even self-made yellow filter, is the best tool to assess ocular surface staining. Because when you do a fluorescein staining, recently we were discussing in one of the cornea classes, your epitheliopathy reflects the fluorescein stain. But what also happens is some of the blue light which is incident also gets reflected. So there's a little fudginess over there. But when you use the Ratten yellow filter, the blue light which is reflected gets cut off, and therefore, like fairy lights, all the epitheliopathy gets illuminated on the ocular surface, allowing you to judge the requirement for the punctal cautery. So that is the first pearl for me. The second one is when the situation arises, not always, you want to test the patency of the punctum so that you know whether you should cauterize it and where it is before cauterizing. I think Prabhat showed that very well. And we have learned in our anatomy days that the lower punctum takes charge of 75% of the drainage and about 25 to 30% is drained by the upper punctum. However, when the lower one is blocked, we know that the upper one takes over almost 90%. May or may not be true every time, but that should be kept in mind before we decide whether one punctum cautery is working or not. And to answer Pete Ma'am's question, I have also had this discussion with some people. Another small reason for reservation by outside people to do the punctal cautery is they feel that the drainage of the inflammatory mediators from the low tiers also is reduced. It basically acts like a blocked wash basin. And, I'm not endorsing that view, but that is one more reason why people feel that punctal cautery should not be done, that the inflammation cannot get drained out from the ocular surface. But then they've been proved wrong because in multiple situations, our ocular surface people have done this procedure very successfully. So the trial procedure of using temporary punctal cautery, earlier we used to use catgut. Nowadays, you can use vicryl sutures is to check two things. Will it work or not is one thing. Mukundan did mention it in the passing. We can also rule out epiphora if we have a doubt. Suppose the Shermer is a little high, 2 millimeter or so, and then you don't want to land up with epiphora doing a permanent procedure. So there again, a temporary punctal plug test can help. So to summarize the summary again, use yellow filter liberally. You don't have to have the slit lamp attachment. You can have a DIY filter also. Punctal cautery is a very simple and very rewarding procedure. One small nugget I learned from my ocular surface colleagues is to keep the cautery on and the current and the thermal effect on while withdrawing the probe. Because if you tend to switch it off and withdraw, then you're inducing recanalization yourself while doing it. It's a lovely video by Mugundan and team to look for the actual procedure. So these would be my take-home points from Prabhat's presentation of the second case.
Yeah, thank you, ma'am. And that was the tips were good. The same thing what we learned from that ocular photography class recently from you. So yes, thank you everybody. And I would just like to ask anybody else wants to add anything, because we have a few of our alumni and people around. Dr. Rishi was there, but I think he logged out. Would have been good to have his opinion because he was at both the institutes.
Thank you. Great presentations and great discussion.
Yeah, I'd like to once again thank PP ma'am, RR ma'am, NR ma'am and Mukundan for giving your expert tips, and thanks specifically to Prabhat. So for coming up with the cases. When I had asked for the presentation, this was I think some 3 months back, and within 2 minutes I had got a ping pong ball response from Prabhat. He's like, I want to do it. So he just, called, it's like I'm calling shotgun type of a thing. So he's like, I'll do it. I don't know what I'll do, but I'll do it. So that's the enthusiasm that we are looking at from our alumni. Thanks, Prabhat. And,
thank you so much. Thank you so much.
Yeah,
Thanks
a lot for including me in the discussion, and the wildcard entry made it more thrilling and interesting. So thank you so very much.
Sripriya just joined.
Lovely, Prabhat. Very nice to have you, as always.
Thank you. Always an honor and a pleasure.
Thank you. Thanks, everybody. Thanks, Srivalli, Shika. Bye.
Ma'am,
thank you.
A big thank you to all of you. Thanks for that.
Thank you for coming over and giving us your tips, ma'am. Thank you, Dr. Shika. Yeah.
Thanks to you. Great program.
Yeah, thank you. And thanks to Dr. GSI and Dr. Mona Khurana in absence here. So,
Nishi is also saying something.
Nishi, you're muted and saying something.
Thank you so much, sir. It was great learning, and it was always pleasure listening to you, sir. Both cases were actually clinically so much relatable.
Thank you. Thanks, Nishi.
sir.
Thank you.
Yeah.
Thank you,
Bye,
everyone.
everyone. Good night.
Okay.
Good night.
Good night. Good night.
Yeah, good night.